We're going to switch gear from prostate cancer to testosterone with an update on the most recent T4DM Australian study. Again, these are my disclosures. As you can see here, currently testosterone approved is really for the treatment of classical hypogonadism, whether it can occur in primary hypogonadism, which is a failure on the testis, or a secondary hypogonadism failure on the hypothalamic pituitary gonadal axis. But majority of the testosterone prescription in the United States are for men with symptomatic hypogonadism related to aging. So as you can see, it doesn't really fit either one of these two categories. So most of the prescriptions were written are actually considered off-label use. A little bit of a history lesson again. In 2004, an expert panel conducted by the Institute of Medicine examined all the data and concluded that there was insufficient evidence for testosterone therapy's efficacy and safety for age-related conditions, including hypogonadism. They recommended a randomized control studies to better determine efficacy and long-term safety in the aging male. In response to that recommendation, the National Institute of Aging funded the testosterone trial, the T trials. These are 7 coordinated trials, placebo-controlled, multi-center, double-blinded study with 788 older men, mean age of 72. They underwent testosterone therapy for a year. And UCSD was actually one of the sites for the study. And with the lead investigator was our late Dr. Elizabeth Barrett O'Connor. What they found was that, not surprisingly, giving older guys testosterone, their T went up. Their improvement in their sexual function. There was improvement in their exercise capacity as measured by distance walk in 6 minutes. There was a slight improvement in their psychological symptoms, but no improvement in their energy or cognitive function. There was an improved bone density. There was also an increase of the size of their coronary artery non-calcified plaque on CT angio. Luckily, there was no significant increase in cardiovascular or prostate complications. However, these studies were not powered for that. We know testosterone therapy and cardiovascular disease is now without controversy, and it's beyond the scope of today to go over that. But we do know that testosterone deficiency is associated with cardiovascular disease and all-cause mortality in our study looking at men undergoing androgen deprivation therapy. Unfortunately, there's conflicting data on the benefit of testosterone replacement therapy on cardiovascular disease. And some of the negative studies had led to an FDA label change to include venous thromboembolus risk in 2005, 2009, 2014. Since those label changes, there's many studies that came out and refuting that risk, and many scientific society has come out and be very outspoken, including the cardiology group, on there's really no link between testosterone therapy and increased cardiovascular complications. Therefore, in 2015, FDA updated their label to say there's inconclusive evidence on this issue. The current, most recent AUA guideline statement is that there's no definitive evidence linking testosterone therapy to a higher incidence of venothrombotic events. Despite this statement, this is our existing algorithm. And you can see that even though they say there's no link, as part of the evaluation, before you prescribe testosterone to a patient, they talk about doing a cardiovascular risk assessment. And patient at high risk should be referred for further evaluation. So as you can see, their language here, they're hedging a little bit on, commenting on this issue. Diabetes is one of the most recognized cardiovascular risk factors. And we know that obesity with or without diabetes is associated with lower testosterone, and it can be reversed by weight loss. Testosterone deficiency is associated with increased risk for type 2 diabetes. However, in randomized controlled trials, testosterone therapy failed to show lower hemoglobin A1C in men with diabetes. And in the later on registry study, they were able to show there's an improvement in glucose metabolism and prevent progression. And the only thing that's been previously shown to prevent the progression from pre-diabetic to diabetes were lifestyle modification with metformin. So back in 2018, a group in Australia decided to answer this question. They want to know if adding testosterone therapy to lifestyle intervention can be better than lifestyle intervention alone in some of the high-risk men to reduce their risk for development of diabetes. And this was funded by the National Research Institute of Australia, a couple of pharmaceutical companies, and a university. So the inclusion criteria, men had to be between age of 50 and 74. These are high-risk guys. They have big waist, waist circumference greater than 95 centimeters. They did not need to have low testosterone. As you can see, the testosterone cutoff here was 403 nanogram per deciliter. They need to have 2-hour glucose tolerance tests within certain range. They had to be willing to participate in a fairly strenuous lifestyle program. These are the exclusion criteria. Men with existing CNS pathology. They are already on testosterone. They are on medication that can affect their testosterone level or 6-hormone binding globulin. Prior diagnosis of diabetes. They have significant glucose problems on 2-hour glucose tests of greater than equal to 15 millimoles per liter. They have existing major cardiac events in the past 6 months, any malignancy, too much alcohol, and also significant psychiatric disorder. And the hope was that they want to look for how many men actually end up having diabetes as defined by greater than 11.1 millimoles at 2-year study period. And also some of the changes from their glucose tolerance test. And secondary endpoints include normalization of blood glucose, initiation of anti-diabetes medications, body composition along with anthropometric measurements, body composition, hormonal profile, sexual urinary function, psychosocial function, and compliance with this fairly rigorous lifestyle program. Patients were randomized. This was a 2-year multi-center double-blinded randomized control study. They randomized to either receiving placebo or testosterone on decaway injection at 0, 6 weeks, and then 12 weekly for 2 to 4 years. Over 19,000 men completed a pre-screening questionnaire. After laboratory and clinical screening, 1,007 was eligible for randomization. And you can see here, 503 men were randomized to the placebo group, 504 men were randomized to the testosterone group. At the end, 370 and 386 men completed 2 years of treatment with attrition rate of approximately 15%, which is very good for a study that includes a very strenuous lifestyle modification program. This is the baseline demographics. Average age of men was about 59 to 60 years old. These are overweight, obese men with BMI of 34, with a waist circumference of 117 centimeters, and a body weight of 107 kilograms. That's over 200 pounds. And as you can see, majority of men have pre-diabetes on their 2-hour glucose challenge test, 80% of them, and 20% of the men had glucose tests really put them in range of type 2 diabetes. However, their testosterone profile, you can see that only 20% of each group had low T. 40% of the group approximately had borderline low, and really 40% of the guy actually had normal testosterone level at the beginning of the study. This is the outcome at 2 years. There was a significant smaller group of men with diabetes at the end of the study period, with 12% versus 21%. And there's also a significant improvement, positive changes from their baseline 2-hour glucose tolerance tests in the testosterone group. And what the testosterone group was able to show, that by adding testosterone to a lifestyle program, they have normalization. A higher percent of men had a normalization of their 2-hour glucose test. There's no changes in their hemoglobin A1C or body weight. There is also a positive changes in the body composition in terms of reduction of waist circumference, improvement of total muscle mass, and reduction of total fat mass. There's also positive changes in their strength, sexual function, with no change in their urinary symptoms at the end of the 2 years treatment group. Not surprisingly, the testosterone group had a higher rate of adverse events, with 22% of the patients experienced a hematocrit greater than 54%. So looking specifically at prostate complication and cardiovascular complications, the testosterone group was associated with a higher rate of arrhythmia, while the placebo group was associated with a higher rate of ischemic heart disease, although these differences were not clinically significant. There was 8 men in the testosterone group underwent hospitalization related to BPH, with no statistical difference between the prostate complications, including 5 men in the placebo group were diagnosed with prostate cancer and 4 men with prostate cancer in the testosterone group. So in conclusion, the T4DM study findings suggest that testosterone with lifestyle modification is better and can also revert men with type 2 diabetes. And these are men without pre-existing hypogonadism. Hematocrit need to be monitored in men undergoing testosterone replacement therapy. And long-term safety and cardiovascular outcomes of testosterone therapy still to be determined. There is an ongoing study called the Traverse trial. This is a 5-year randomized control study specifically looking at complications relating to testosterone replacement therapy in older men. The study was just closed. We hope to have the results next year, so maybe I'll come back next year, give you guys an update on that study. Thank you for your attention.